second. I'm going to start recording. And share. Okay, chapter 2, the skeletal system. Okay, so a little bit of this is going to be review, and then the last part of it would be probably kind of new. So just make sure you pay attention and stop me for questions along the way. Okay. Okay, functions of the skeletal system. Most of them are self-explanatory. Give support and shape to the body. Well, that's a no-brainer. If we didn't have a skeleton, we'd be a big blob of jelly. Protects vital organs. Yes, it does protect our vital organs. Think about your rib cage, protects your heart and your lungs and your diaphragm, and then your stomach is partially under that, but then the rest of our organs are kind of open. But our rib cage does protect a lot of our vital organs. And then our pelvis actually itself does that too, because our pelvis is kind of on the inside, it's kind of a bowl shaped, and we have a lot of vital organs that are inside of our pelvis. Assisted movement. Obviously, if you didn't have structure to your body, you wouldn't be able to move. And manufactures blood cells. So this in the middle of our long bones, that's where our marrow is, and that's where we produce all of our new blood cells, red blood cells, white blood cells, other lymphatic cells, and immune fighting cells, things like that. Those are manufactured in the middle of our bones. Okay, so we divide the skeleton into two sections, the axial skeleton and the appendicular skeleton. Okay, so on this picture here of the skeleton, all of the bones that are shaded in light blue are the axial skeleton. Okay, now think about this. Look at what it includes. It includes the whole spine, the rib cage, and the sacrum, and the head. So all that is the middle of the body. That's where all of our axes are for turning, for twisting, for bending and things. So that's the axial skeleton. Think of the spine as the axis of our body. The appendicular skeleton is kind of easy to remember because it's everything else that the axial skeleton's not. Or you can also look at it as it looks like appendage. The limbs are appendages, so the appendicular skeleton is the skeleton of appendages, including the pelvis. So it's the arms, the legs, and for the arms that does include the scapula, because that is part of the shoulder complex. And then for the legs, that does include the pelvis too, but not the sacrum. The sacrum is not part of the pelvis. The sacrum is part of the spine, so don't get that mixed up. Okay, well, there's two types of bone that we normally have. We have compact bone and we have cancellous bone. Well, compact bone is what we normally want. So let's look at this picture of the left side of your screen of A, B, and C. A would be the cross section of the bone, and then the B picture is the actual cells. Those are actually what the bone cells themselves look like. The osteoclast and the osteoblast that produce and degrade bone cells, and so they keep the bone always kind of changing and always stable. And then you can look down even further at the C right here, and that's what it looks like on the microscopic level. It's not quite solid, it's more of a lattice, kind of more of a network of scaffolding, if you will. It's still pretty dense, You can see here, in this other picture, there's a cross section of the skull, and you can see the skull's not very thick, but if you look at this real picture over here, I don't know how, you probably can't see it on the screen that I'm, you probably can't see it on the screen that I'm sharing, But if you look at it on your own PowerPoint slide, pull it up on your own, you'll be able to see there's little bitty holes all the way through there. Okay, that's just part of the lattice network of the bone. Now we'll come across bones that don't have enough lattice network in a minute and that are not very dense. Okay, this is a picture of a tibia. Tibia over here looks like this cross section of the tibia over here. So this is just a review, probably from A&P. Did y'all have all these in A&P 1?
Yes.
Yeah, I figured y'all did. So I'll let y'all memorize that and go through that. Just, you know, if you can't find, the answers are in your Kines book, nice, and this drawing is straight out of your Kines book, or you can use your A&P book, and if you want to get a deeper definition. Okay, let's talk about what ossification is. Ossification is bone formation, okay? Another name for it is osteogenesis, okay? That means osteo is bone, and gen or genesis means beginning. So this is the beginning of bone. So this is bone formation, okay? So bone formation occurs 4 different situations. While we're as an embryo, we're forming our bones. Growth after we're born and we're toddlers and newborns and growing into kindergarten, our bones are not quite mature yet. So our bones are going to keep maturing about until puberty, until our mid-teen, until probably late, maybe early puberty to mid-puberty is when our bones would probably stop growing and you'll reach your full height. Remodeling of bones. So bones are always remodeling themselves. So they're always getting rid of the old bone cells that have been around for a while and then recycling them and then making new bone cells. So the bones, just like all the other tissues of our body, are always remodeling themselves, always staying up to date and new. And the other time bone formation occurs is in repair of fractures, obviously. So if you've ever fractured a bone, you know, you have to they either have to put you in a cast to keep that body part still for a certain number of weeks so the pieces can heal together, so the ends can heal together, or they may have to do surgery too. But in either case, the 2 ends of the bones are going to start growing back together until they're fused as one again. Okay. Now, this would be, look at this picture. This would be what bone and cartilage looks like in a newborn. So everything in this picture that's white is a bone that's already formed in utero. Everything that's purple or blue on your screen, I see it as purple, but I'm half colorblind. I don't know what you see it as. That's all cartilage. Well, look at how much cartilage makes up the infant skeleton. The infant skeleton is so immature. Look at that. If you look at it, just start at the skull. Look how much of the skull is immature and hasn't fused together yet. Most of us know that we have to be really careful with a newborn and an infant's head because their plates of their skull are not fused together yet and sutured. Well, look at the rib cage. Look at the front of the ribs and the sternum. Almost all of that is cartilage. Look at their hip joints. Their acetabulum and the head of their femur don't even look like they're formed yet. They're just cartilage that's stuck there. Their pubic bone isn't connected yet. Look down at their ankles. Look how much of their ankles and their toes and their knees are all made out of cartilage. So they're that's why babies are very, 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 very flexible, one reason. But it is also, it takes them a little while to develop and gain motor skills because they've got to wait extra months before their bones develop, before they can start bearing weight on their elbows and their hands and their knees for creeping and for crawling, and then for eventually walking. They've got to have enough of this cartilage that has formed into bone. But not all of it is going to form into bone by the time they start walking. I'm just saying some of it will. But you'll learn a lot more about this in growth and development with Dr. K this semester. Okay, this is another example of the bone formation. So look at these are x-rays. So look at the x-ray of the toddler on the left side of your screen, and you can see everywhere where there's a white, where it's white, that those are the bones. Well, if you look in the wrist, I don't even see the carpal bones yet. And between the carpals and the metacarpals, you can't even see any conjunction or any joint juncture at all. So it just looks like they're just kind of floating there. Then a few years later, let's look at the picture in the middle. A lot more mature. This would be a school-age child. Let's just say first, second, third, up to fifth grade. So they've got, you can see most of their carpal bones, most of the bones in their hand have grown a lot longer. They've got cartilage on the end, and some of them, and you can see the thumb is already starting to articulate together. And then you see a young adolescent. Just a few years later, their hands are fully formed. You can see all the carpal bones. You can see all the MCPs joints. You can see all the phalanges and the interphalangeal joints. So it's all matured. And that's normal with all of us. Okay, any questions about development before I move on? Quick drink of coffee. Okay, it's pretty self-explanatory. You've probably had that before. Well, let's talk about, let's shape bones. Let's talk about the different types of bones that we have in their body. Most of them are named for the shape that they are, and it's pretty self-explanatory. Some of them are a little different. But we have long bones, short bones, flat bones, irregular bones, and sesamoid bones. We only have a few sesamoid bones in our body, and when we get there, I'll show you what they are and what's so special about them. Whoops, sorry. But this picture of, where's my mouse? The picture here of the femur. This is a femur. This is an example of a long bone. Okay, obviously because it's long. Your tibia is a long bone. Your radius and your ulna are long bones. Your humerus is a long bone. Okay, let's look at B, short bones. Short bones would be like your carpal bones. The carpal bones in your wrist are little bitty short, round rock-like formations. I mean, I shouldn't say rock-like formations, but if you look at them one by one, they do look like kind of like little pebbles. Those are called the short bones. Okay. Now, B would be our flat bones. Really, the only definition of a flat bone in our body is our sternum. And if you see the whole sternum, if you look at the sternum from the xiphoid process up to the manubrium, that is pretty flat. It is exactly flat. The manubrium, whoops, sorry. Sometimes this is called the manubrium of the sternum. Sometimes that will flex backwards a little bit, but sometimes it will be straight too, just like the sternum. But this is called a flat bone. Okay, irregular bones, vertebrae. This is a bird's eye view of a vertebrae. No, just think, where would that fit in the body, in any other joint? Only the back. These just have to stack on top of each other. That's pretty much it. They got all these spinous processes and transverse processes going out, so they're very irregularly shaped. And then sesamoid bones. Okay. So we only have a couple of sesamoid bones in our patella. Okay, sesamoid The word sesamoid translates to sesame or sesame seed. Okay, so it sounds like a sesame seed. Well, a sesamoid bone is a tiny, tiny, tiny bone. Your patella is one example. And then at the MCP of our thumb joint of our first digit, we have two sesamoid bones there inside the joint of the digit, okay? And that's about the only place we have sesamoid bones in our body. They're teeny, teeny, tiny inside the thumb joint, not the other fingers, and then each patella is a sesamoid joint, okay? Now, what a sesamoid joint bone does, I'm sorry, I've been saying sesamoid joints, it's sesamoid bone, sorry. Sesamoid bones, and we should have a slide on this a little bit later, just increase the lever arm of a tendon to allow greater muscular efficiency. So it almost works like the pulley of a crane, like you see cranes lifting heavy things to build buildings, and at the top there's like a pulley. That's kind of like what a sesamoid bone acts like, is a pulley system to allow more weight to be carried across that joint by the muscles. Okay, let's look at some common skeletal pathologies. So let's look at this black and white picture first. This is a knee, this looks like a knee joint. Well, if you look really closely, if you find the label where it says epiphyseal fracture, and you can see that joint, you can see that top point, the diaphysis of the femur has separated from the epiphysis of the femur. So that would be a growth plate joint. So that's a no bueno place to have a fracture. It looks like that whole femur has just shifted over. So that's going to be that's going to either have to be a surgery or a very long time in a cast. Over here on A, B, and C, the color pictures, these are pictures of a bone with osteoporosis. As you all know, osteoporosis is when your bones have less bone density, less calcium density. Osteo is bone, porosis means porous. So porous means it has lots of holes and tunnels that go through it. So these top pictures are vertebrae, and you can see this one that I'm circling, the big square, is a vertebrae that has, it looks pretty bad. It's got, it's pretty much got a lot of very, very, very undense calcium networks all throughout it. This second one that's much, much flatter, well, sorry, believe it or not, this is a vertebrae too, but this vertebrae has had what we call a compression fracture. So if you've ever noticed or ever heard the tale or just noticed on yourself that as older people age, a lot of them tend to get shorter, maybe they lose a few inches, and then they tend to hunch over a little bit. That's due to compression fractures of the spine. Okay, now a compression fracture of a vertebrae sounds like it's a pretty traumatic event and like it would crush all your spinal cord and your nerves. Well, in some cases that does happen, but most of the time it's actually not just a one-time thing where your vertebrae goes from being weak and then just goes crushes. It's over time, it's over weeks or months that your vertebrae slowly gets smaller and smaller as it just kind of gets crushed, basically, for lack of a better term. And you just tend to lose a little bit of height. You might flex over a little bit, and people will typically feel a little bit of upper, and this usually happens in the thoracic spine. People tend, or the cervical spine, people will tend to have a little bit of pain there, but it won't be as much pain as you think it would be. It would just be like a really nagging pain. They might want to put a heating pad on sometimes or something. And then these other pictures, B and C at the bottom, are just close-up pictures of a bone with osteoporosis. I mean, you can see it's not very dense at all. Very, very weak. Okay. Other skeletal pathologies, so osteomyelitis. So osteo is bone, myel is myelin, itis is inflammation. So this just means inflammation of the bone, usually the inflammation of the covering of the bone. So we know the bone doesn't have myelin, but the bone does have covers and layering. So this is infection of the bone. So you can see this looks like two MRIs or CTs of, it looks like knees, or maybe looks like knees, or I can't really tell, maybe elbows. But you can see this one over here on the right has quite a bit of infection in the bone. You can see all these holes. Sorry. You can see all these holes compared to the other side that's nice and normal. You can see where there's already some tunneling of the infection, and there's already some holes over here on this bone too. So this is a pretty bad osteomyelitis. This is a pretty bad bone infection. These can be due typically, most commonly, with an open fracture where a person has a fracture and a parcel or a piece of the bone pokes through the tissues and goes out the skin and makes an external wound. That's a common cause for osteomyelitis. You can get it from having other infections too. It can result in the loss of that limb or the loss of partial limbs sometimes if they don't catch it early enough, or depending on how bad it is. Okay. Epiphyseal disorders. So this cloudy x-ray that you're looking at is looking at the front of probably a child or a teenager, and we're looking at the front of their pelvis. So we're looking at their hips and up where it says, see where it says normal capital femoral epiphysis. So that's where their acetabulum is. Then we see the pubic bone coming together in the front. Well, the first pathology, and they're both kind of the same, they're just a little bit different in how they work. So the first one is called leg calf Perth's disease, or avascular necrosis of the femoral head. Okay, so this just happens. This is a very common disease in adolescent boys, especially boys like around 13, 14 that are getting into sports like football and track and field and stuff. They will tend to have it tends to come from maybe an overuse of their acetabulum, or there's an artery that goes right through the acetabulum into the femoral head, and it could be a kink of that artery, but it starts causing the femoral head to lose blood flow, and it slowly starts to die. That's why we call it avascular necrosis. Avascular is no or little blood flow, necrosis is dying. So in this case, it would be the femoral head would be slowly dying, not separated or not fractured, it's just slowly dying. So in this case, they would be on, the patient would, if they caught it, well, first they would start having a lot of pain with standing and pain with ambulation. Hopefully they get to the doctor in time, and they're going to start on a lot of strong antibiotics and a lot of strong drugs to try to stop this. And maybe even have to do a surgical procedure. Slipped capital femoral epiphysis is another pathology. This is when it's a fracture of the growth plate at the femoral head. So the femoral head in the epiphysis of the femoral head actually separate. So inside the acetabulum, so if my hand is the acetabulum, if you can see me, and then this is the head of the femur, well, the head of the femur stays in the acetabulum, but right at the epiphyseal line, it breaks off. Or it doesn't, I shouldn't say break off, that sounds pretty bad, but or worse than it is, but there's a fracture between the epiphyseal line and the head of the femur, okay? And both of these pathologies, basically, let's see if it shows you in the next one. Nope. Both of these pathologies, basically, the treatment for them is unless they if they may have to do a surgery if the artery coming out of the acetabulum is being kinked or something. But usually you're in a long leg cast and you're casted with both legs casted, and you're casted with a bar between your legs into abduction of both of your legs, both of your hips, and basically you're stuck like that until it heals. That's basically they abduct your leg that far and cast it there because that's the position where all of our hips, everything in the hip joint is at its most congruent and touching. So they want it to heal that way. They cast the other leg and put a bar between the legs so you can't move either leg, because if they didn't cast the other leg and immobilize it, you would always be able to abduct and adduct your fractured leg. But now that they've immobilized both of your legs, you basically are stuck. So that's, I know it seems kind of archaic, but it's the only way that they can get that to heal. And there was a guy in C8, I think he was in C8, and he had slip capital femoral epiphysis when he, no, I'm sorry, he had avascular necrosis when he was I think about 12, and had to be in those long leg casts, and they're called spica casts usually. He had to be in those long leg casts with the bar for a while until he healed, and he said it was terrible. It was just terrible. Okay. Another common pathology of the skeletal system is called Osgood-Schlatter's disease. You may also know this as overuse of the patellar tendon, because that's actually what it is. It's an overuse on the patellar tendon. Okay, so it could be, a lot of times this happens to teenagers or people during athletic, people that are athletes or practicing for sports a lot, particularly track and field, or things when there's a lot of sprinting and jumping. This is a overuse of your patellar tendon, and it provides too much traction and too much pull on the tibial tuberosity where it inserts. So you get inflammation and pain of the patellar tendon and the tibial tuberosity. The tibial tuberosity is going to get actually bigger. It's going to get inflamed. So I would say, and now this goes away after a while. You get rid of it you can get with lots of icing, lots of rest, and lots of slowly getting yourself back into activity as the pain is subsiding after time. I would say that in every cohort, there's always a few people that have Osgood-Schlatter's disease and have giant tibial tuberosities because of this, and that's a telltale sign. So we'll see in the next lab, when y'all come to lab, who has had Osgood-Schlatter's disease, because sometimes it's pretty obvious to tell. Not that we're making fun of you, but you'll be the people with big tibial tuberosities. And it's not anything that's more male or female. It's the same, male or female. Just really it depends on your activity style and your active life during teens and young adulthood. Mostly happens because the epiphyseal plates haven't closed yet, but after the epiphyseal plates closed, usually at the end of puberty or late teens, this usually won't happen so much again. If it does happen again in adulthood, it's not because of it's inflamed of the tibial tuberosity or the epiphyseal plates, because those have fused. In adulthood, it's going to be just use of the patellar tendon, and that's going to be sore and inflamed. But in the teen years, it'll be patellar tendon and tibial tuberosity. Any of you think you may have had this before or ever had to go to therapy for this?
Yes, but they said mine was, well, they thought I had this at first, but it was actually osteochondroma.
Okay. So something
Yeah.
a little bit different. Yeah.
Mm.
I played basketball and I was diagnosed with Osgood-Schlatters by an athletic trainer.
Yeah. Are your tibial tuberosities a little bigger?
Yeah, I would say that.
Yeah. Yep. That's pretty common. A lot of basketball players. It's really common in basketball players because think of it. You're always springing up and doing a little jump before you or a big jump before you take your shot. So you're using those quads to push you up, to spring you up. So basketball players get it. Track and field people get it. Yep. Anybody can really. Okay. So let's see. I don't think I'm gonna quiz y'all on those because you know those. So that is the end of the lecture on the skeletal system. Probably mostly a review for you from last semester, if anything. But are there any questions from this for today? Especially on the pathologies I went over, because that might have been the newest thing for you. Okay. Well, if there's not, then you may go a little early. So I don't think you have class again until 10. Am I right?
Yes.
All right. Well, if anybody asks, you got out right at 9:55 with Mr. Allen in kinesiology. So he had a lot to cover. So just let the next teacher know if they ask.
I have
But
a
anyway,
question.
okay.
On our syllabus for techniques, PTA techniques, it says we
Yes.
have a test on Monday.
You do have your first test on Monday.
What is it over?
Okay. Well, it's going to be over all the PowerPoints we went over up to so far. Now, I'm going to send y'all, you and Mariah, this is because of your email. You made me think of this yesterday. As soon as this class is over, I'll go grab my book and get the updated chapter numbers, because the chapter numbers differ than last semester's because the book changed editions. But they should be the same, but it should just be the first few introductory chapters. But it's going to be for sure introduction on like my PowerPoint on introduction to agents, and then the tissue healing and the inflammation process. You've also learned the cardinal signs of inflammation and pathology a little bit, so that would be on there. And then what we've learned about hot and cold so far.
Thank you.
You might have to know, I wouldn't say you need to memorize all those skill contraindications for the test, but just be familiar with the main ones, like about, you would never put a hot pack over an open wound or a rash or something. Let's see, do we have a specific time to take the test? Yes. So the test will have to be taken during class period on Monday, because you do have another class right after that. So it'll be open from it'll be open for everybody from starting at 8 o'clock. And if for those of you that need extra time, I will open it about 7:30 for you, because I can't tack the extra time on the end because you have another class after that. But if you have permission to get extra time, I'll tack it onto the front end, okay? And I'll let you know about that specifically so you'll know when you can start.
Thank you.
Okay, but I'll send y'all an email in just a minute about the specific chapters in your book to read through, okay? But make sure you don't just go through my PowerPoint. Make sure you review the book too, because it kind of helps everything come together nice and neatly. Okay, if y'all don't have any more questions about anything, you may go.
Thank you.